Everything you're about to see on this video is a combination of my 40 years of study of the published literature, as well as 30 years worth of patient contact as a colorectal surgeon. I'm not here to diagnose or treat anyone. I'm here for educational purposes only because no manner of brains is worth a good set of bells. Hey, it's Dr. Toker, your friendly neighborhood colorectal surgeon, and I am on a mission to educate the world in terms of gut health and the microbiome and how that impacts your daily life. I certainly hope you will join me on this journey, but you're going to have to buckle up, Buttercup. We're talking gut stuff. And hello once again, everybody. It's been a long month of organizing my gut check program into a subscription. And I will tell you, we are making moves. It's a lot of information. And I wanted to make sure that we could break it up into sort of like little weekly bits of information that subscribers would get with references and that sort of thing. It's been sort of an undertaking. So normally on these sponsored podcasts, I will spend about an hour of time describing a variety of different diseases and then how I would use medical management, including a non-invasive, externally applied medical device called the Super Patch. And then the Super Patch company does sponsor me in this podcast, and I also sit on their medical board and help them go over research studies, et cetera, in their pursuit for excellence. So that's just sort of what the mission of these pre-recorded, longer format videos are. Now, for the rest of this month, I am going to do something slightly different in that I want to do a journal review as opposed to disease and how I would treat. We're going to do the science. Now, I spent the month of September doing 4 different lectures that describe something called piezoelectric channels, how they convert one signal, whether it is light, sound, or touch, into an electronic signal, which then can communicate both with neighboring structures as well as the brain and therefore the rest of the body. It is these piezoelectric channels that are being harnessed with this super patch technology. Okay, so the whole point of those lectures, as fascinating as they may be, was to educate people on the physical therapy devices. These are considered medical devices. They're not considered medicine. And it is interesting that in some of the feedback that I get is, well, there's no medicine on it, therefore it's placebo effect. Or how do you know that it works? Or, have they been tested, et cetera, et cetera? And of course, my answer is, well, first of all, they wouldn't have brought it to market. I know that sounds very naive, but this is a technology that is registered with the FDA. So it is true medical technology in the same way a blood pressure cuff checks your blood pressure. That is an FDA registered device. And so this is a FDA registered device. The company, prior to bringing something to market, will design a device, will use EEG, electroencephalogram tracings, to determine which part of the brain is being activated and normalized by the device. And we've talked about that. These devices are designed to take pathways in your brain and normalize the signal to a homeostatic baseline. So when your body is in chaos, your brain tries to compensate. You can actually detect this compensation on an EEG even before the disease shows up. We have discussed that in other videos. And so the goal in life would be the earliest possible detection and the earliest possible intervention to try to prevent a disease instead of the reflex nature. Eastern and Western medicine, allopathic, osteopathic, we all engage in the same process, which is we wait until a diseased patient comes to us, and then we apply an intervention. And so the reason I'm associated with this company is because of the concept of how early can you intervene on a problem and therefore prevent the physiologic consequence of a disease long before it shows up. And so that technology exists. It just needs to be developed. And I'm proud to be part of this development process. Anyway, the development process involves number one, addressing a common need that we might have. Number two, identifying the part of the brain that's responsible for the neurologic control in that disease process or dysfunction process. Then number three, figure out what pattern does one need to fire piezoelectric channels off at in a way that can address that part of the brain. And then the final step is take patients who have symptoms in this pathway, apply to the devices. Number one, does their EEG normalize? And then number two, do their symptoms abate? So these devices are not used to diagnose any disease, and they're not used to treat any disease. They're used to help a patient adjust to the symptoms. It's a symptom combating technology, for lack of better words. Now, the next couple of weeks, what I'd like to do is go over the research studies based on this technology in certain disease or symptom pathways. I shouldn't say disease, symptom pathways. The first one we're going to address is the pain pathway. And this was the first thing that attracted me to this company because I do not use narcotics as a surgeon. Patients who have surgery, who use narcotics, are much more likely to have difficulty healing, get addicted to the medicine, or suffer some complication as a result of the narcotic usage. So surgeons in general are getting away from using narcotics for surgery, but we don't want you in pain. So then we have to engage in this multimodality of therapy for pain. So the pain pathway is an important one as a surgeon to address. Now, I personally am having surgery at the end of this month, so I am quite interested in the effects of this device. And I also know it happens to work because I use it to control the pain that I have from my autoimmune disease. Okay, so we're going to talk about the pain pathway, and you'll excuse me for a minute because I've got to share my screen so you can see the paper. This is the one I want. Okie dokie. Now I am hoping y'all can. Oh, you can't see the whole thing. What a bummer. I wonder. Hang on. That's what you get for doing sort of live view. Am I getting more of it? I am. I'm getting more of it into the little thing. Hang on. Of course, now you need a microscope to read it. But I will go through it for you, and then you can find this yourself if you want to. This is a research article that is from a journal called Anesthesia and Pain Research. The research was done out of the University of Miami. It is from 2022, and let's get the actual. It's going to be 2022, and it looks like it's going to be in the second volume of the June edition, pages 1 through 7, if I got that accurate, right? So anyway, volume 6 of Anesthesia and Pain Research. And then this ISSN number is 2639-846X. And this way you can find it in the general research database if that's the way you look at your articles. And otherwise, you can just read along with me. I believe the Super Patch company does publish this forward facing from their website. I did have them send me this article, and it's an interesting one. It is based on the concept that these patients in this article are all suffering from chronic pain. And I think the research on chronic pain made the nightly news, or maybe I'm just aware of it because I follow the medical literature. But chronic pain, 80% of chronic pain has been isolated as a particular pathway in the brain. So they've isolated the part of the brain that is responsible for your body's perception of pain, and then thereby controlling that pathway can actually remove a certain amount of chronic pain. So pain is a very interesting thing. Your body senses something to tell you that there is an alert, but there's so many emotional components to pain and neurologic stimuli and inflammatory and stimuli associated with pain that it's a rather complex issue. What I found as a surgeon, so in our practice as surgeons, a lot of the steps that we take before and after a surgery are to try to prevent pain in the first place. So, for example, if you're coming to me for an operation, no matter which one it is, if I'm doing a major robotic surgery, if I'm doing a hemorrhoid surgery, I am going to inject a nerve block, or the anesthesiologist will inject a nerve block prior to making an incision. And this data goes back, gosh, I would think I was in my residency when they were really investigating this heavily. So probably 27 to 30 years ago, it became apparent that if you inject the lidocaine or Marcaine, or in our case, we use a long-acting Marcaine called Exparel, if you inject that prior to making the incision, the pain scale after surgery is better than if you inject it at the end of the surgery. So there used to be a thought of, hey, look, this numbing medicine is only going to last 8 hours. This is a 2-hour surgery. So let's inject it at the end of the surgery. That way the patient has more of this topical injected, anesthetic on board for longer after the operation. And so that was kind of the way things were done. You're under general anesthesia, you had a surgery, and at the end of the surgery, nerve block was done. The local anesthetic was injected into the wound right after, or we even had these, what were called on-cue pumps. If there's any medical people out there, people who had surgery 20 years ago, they still, I think, use the on-cue pump. It's like a little catheter, and it's attached to a bulb, and that bulb slowly drips numbing medicine into the area. As a colorectal surgeon, we used to, in my training, we did a lot of epidural anesthesia, actually. So put the patient to sleep, do an epidural anesthetic, do the operation, leave the epidural in place, and pull the epidural several days post-op, and that was the pain control to limit the narcotics. We've gotten away from that epidural because we are concurrently trying to prevent people from getting blood clots in their legs, so we put people on a blood thinner. Well, you don't want a catheter in your epidural space if you're on a blood thinner, because you can have a spinal complication. So, things got complicated as we try to prevent all of these complications. So it then became, okay, nerve blocks. When do we do the nerve block? And where do we apply this nerve block? And are there any super long acting things that we can do? And anyway, long and the short of it is, in the series of studies describing the postoperative period of time and pain, patients who had a nerve block prior to making the incision. Now, all these patients are under anesthesia anyway. Like you will not feel this nerve block. You'll be asleep. But if you make the nerve block before you make the incision, the patient experiences less overall pain and has better postoperative recovery than if you inject the nerve block after you've made the incision. And that sounds counterintuitive because you don't get as much of the block in the awake state, and that's not what's important. What you're trying to do is you're trying to block the signal to your brain. That way, the neurologic component of pain is not activated as readily as if you were to go through an entire anesthesia. So you may be asleep, but your brain is still sensing everything that's going on. The inflammatory cascade of your body is being set in motion as a result. Even though you don't consciously feel it, the autonomic nervous system, the part of your brain you cannot control, feels it. So that is kind of the logic step. If you can just kind of follow the last 30 years of pain management in the surgical world, these are the kind of steps that we're coming up to. We're finding that giving narcotics before and after surgery worsen the patient's pain in the postoperative period. Shocking, I know. And a lot of patients are scared to have surgery without like a narcotic pain medicine. And you just have to assure them, we don't want you to have pain. We're going to do a number of things to prevent your pain. But narcotics should not be one of them because you'll have a worse outcome. Okay, so that's the logic behind looking for these alternative treatments to pain. Now, in this particular paper, in the Anesthesia and Pain Research Journal of 2022, Volume 6, they are describing applying a topical physical therapy device made by the Super Patch company. It uses something called Vibrotactile technology, which is embedded into a little sticker. Let me see, we'll scroll down to what the little sticker looks like, just so y'all know. This little red square is what we're talking about. That is the little sticker, and in this sticker is a texture. You cannot see it with the naked eye, and that texture will trap the skin in a very particular way. And as the patient naturally moves over the course of their day, it triggers a tactile sensation that goes to the brain and calms down the part of the brain that's responsible for chronic pain. I know that seems very Star Trek. To me, it does anyway. Maybe you guys are less impressed. I don't know. But this part of the brain that is responsible for pain can be neutralized or calmed down, for lack of better words, with this particular device. And to show its efficacy, so they already knew this based on EEG studies, and they already got the hint in patients who were just randomly saying, oh yeah, I tried the thing and yeah, it worked. Okay, well, let's be a little bit more scientific than that, right? So they used the pain medicine department at University of Miami, got IRB approval, which if you don't do research is an important thing. It means you're using human subjects to study on, and that you're going to use outside researchers to do the research. And while the company who makes the devices will freely give the devices, they're not actually involved in any of the research. Okay. And it is a complicated process. I'm in the process of trying to get IRB approval for one of these studies to try to prevent falls in the hospital setting, which is an important medical problem, especially in the surgical world. And 9 months, 10 months, maybe we've been waiting for the IRB approval, which I do hope is shortly coming. Our study will be very similar to this one. We will have a group of patients, and that study will take place over a couple-week period of time. We will have placebo patches in addition to therapeutic patches. So in this study, there were 145 people, I think. The font is so small now, so y'all can see it, and I can't read the numbers, but 140 some odd people are in this trial. There is a treatment group and there is a non-treatment group. The non-treatment group will also get a little sticker on their skin a placebo. There's no texture to it. You can attach those people to an EEG. Nothing happens to their EEG. And we put that on their skin. Does anything happen to their pain? And then there's the treatment group. The treatment group, you can show EEG has changes as a result of the patch. Now, over the course of a 2-week period of time, we check the pain level in these patients as well as the amount of pain medication they are asking for in this period of time. And then we test those two groups for statistical analysis. And what you can find is that patients over the course of a 2-week period of time have about an 80% diminishment in the amount of their pain based on standard pain quality index questionnaires, and as well as a decreased amount of pain medicine that they request, which frankly, that's kind of the end goal. Our goal is what can get the patient to feel like they don't need the pain to reach for the pain medicine. Because the less pain medicine you use, the less stress you are under because you're not hurting, the better you are physiologically to heal a wound. When you are in pain, your body does not heal well because of a stress and inflammatory response. So we don't want our patients in pain. Unfortunately, narcotic medicines increase the inflammatory response and have a myriad of long-term complications, which can make the patient's overall outcomes worse. Okay, so this is a means by which that we can apply a non-prescription medication. It's not a medication, it's more like a physical therapy device. Think of it as an ACE wrap that might make your ankle feel better when you've sprained your ankle, or crutches that make it easier for you to walk after you've injured your knee, or something to this effect, right? Think of it as a brace. It in the insurance world has the same CPT code as placing what they call K-tape. These are therapeutic physical therapy devices, an externally applied physical therapy device. That's what this is. It's just commercially available and does not require a prescription. And so sometimes that's what causes the undue confusion. Anyway, so the long and the short of it is, in this study, it shows viability of, and these are the references, and you can find this paper online. Basically, it means that you can use a non-medicated, externally applied, FDA-registered physical therapy device. It's called a super patch. The one studied here commercially is known as the Freedom Patch. It's a little red square. And you can apply it to acute or chronic pain. The way one would apply that is as close to the point of maximal intensity as possible. However, a lot of these patients had more than one area that hurt. So, but you only need one patch, you don't need multiple. Wearing 2 or 3 patches does not improve your outcomes. What you'll want to do is wear this patch for 24 hours. In the shower, take it off, dry off, apply another patch, and do it daily over the course of a 2-week period of time. If you either have chronic pain or if it's acute pain, do it for as many days as it takes to get out of that pain, and then you can stop using it, and then if the pain comes back, you can reapply it. We usually will suggest people apply this as close to an operative area as possible. Now, when I do butt surgery, this is not an easy thing. I'll be quite honest with you. But I think if you put it as close as you can on the low back, either side on a butt cheek, if you've had rectal surgery, I'm about to have neck surgery, endocrine thyroid thing. And so I would just sort of put it as close as I can to that wound without contaminating this wound and without disrupting the wound by removing the Band-Aid when it's removing the device when I need to remove it. So I'll have to figure out where I want to put it after my surgery. But anyway, so that's how you want to use it when you're no longer hurting. 3 or 4 days out from an acute pain issue, 2 weeks out if you have chronic pain. If your pain is gone, you can stop using it. I personally used this on my knee when I was incapacitated with my psoriatic arthritis. It turns out some of my pain may be related to this parathyroid issue, which I'm looking forward to. I hope that's the case. But when I am hurting, I will apply that to the knee that hurts the worst. All my joints hurt. And then, yeah, if you use it every day for 2 or 3 weeks, you get to where really all of your joints become quite functional and you've taken no medicine. And it's one of the ways that I have rehabbed my way out from taking prescription medicines for pain. And I'm not saying everyone can do that, but it would be a goal. It's a goal in my surgical patients. It's a goal in myself personally to never use narcotics if you can get away with it, and to minimize the amount of prescription type medications or even over the counter medications that are required. Of course, I also utilize a high protein diet that's clean, has no gluten in it, that utilizes a lot of phytophenols from fresh fruits and veggies. I do a lot of turmeric and ginger. There's something called Boswellia, which is an amazing anti-inflammatory. Arnica montana is a very good herbal medicine for bruising. All of these types of things can assist. There's something called gotu kola. If I'm pronouncing that correct, it's 2 words. That's a very good pain medicine as well. And vitamin D is extremely effective in patients who are trying to heal operative wounds. So is vitamin C, and even vitamin E. Get your collagen, get your hyaluronic acid, get your protein. All of these things help improve healing. I personally also suggest to my patients a stem cell stimulating herbal supplement called StemRegen, and I suggest taking it 2 weeks before surgery, 2 weeks after surgery. So I start taking mine next week in anticipation for my own surgery. So that is Journal Club. I hope y'all like Journal Club. Next week we'll probably bring up the sleep study. Sleeplessness is a big issue and leads to a lot of chronic illness. So I feel like this and I know for a fact this the REM sleep patch works fantastic. So next week we'll go over journal review on the studies done on sleeplessness using vibrotactile technology, and hope you guys enjoyed journal review. Just a quick note before I go on my gut check program, which, and many of you have already signed up for my online program, and bless you for doing so, because that helps pay for my video stuff, platforms, and for my cybersecurity. It's a shame that I need that, but you'd be surprised how many haters are out there trying to crash my website. It seems so rude. But I guess pharmaceutical industry doesn't really like what I say. Anyways, but it's expensive, and the information is critically important. I'm a firm believer that the last 30 or 40 years, and maybe it's been going on longer than that, but you can truly see a physiologic response in the population for the worse in the last 30 to 40 years. Correlation is not causation. There's a lot of things that have changed in modern life in the last 40 years. It's very difficult for us to peg which one was it, or is it just a accumulation of all these things that are causing human disease. But a lot of people don't realize that most illness starts with inflammation of the intestinal tract. Now, I was a microbiologist for years. I'm a surgeon that operates on the intestinal tract, and I don't think I ever put those 2 and 2s together until probably 5 or 6 years ago. And the research is there, and the research has been there for probably about 20 years, particularly in the microbiome world. It's been there probably about 20 years, but it doesn't really penetrate deep into the educational system. It doesn't penetrate deep into the public purview. So a lot of your doctors don't realize this information, or they know it in the back of their minds and they don't see how it's kind of related. And my goal in life, because I do agree with the concept, let's make America healthy again. That's important. We're poisoning ourselves and we don't realize how or why we're poisoning ourselves. And I'm not going to get into the conspiracy aspect of it where people are poisoning you just to be rich. I don't know if that's true or not true. I do know the conveniences of modern life that we all love and enjoy are very likely the things that are making us sick. And yes, big corporate entities may or may not know that what they have in their products are making you sick. I don't know, right? They may have no idea, but the research is becoming more and more obvious that known things that you are currently consuming in high amounts are damaging to your body. Now, so that's part number one. Part number two is, what does your body do with that stuff? How do you clear it out of your system? How is it negatively impacting you? What can you do proactively, not only to stop that input, but to normalize what your body is doing? And that is the purpose of my educational program. It's 100 different topics. And so if you bought the program, you bought a 300-page dossier and probably 24 videos of explanation. But and I think the price is reasonable considering the amount of information, but the average person may not have $175 to plunk down on something they don't know if it applies to them or not. I'll tell you it does apply to you, but then I also benefit if you buy it, so don't take my word for it. It may be better if I had a less expensive subscription format and we could dole out the information at a controlled rate, and you can stop paying the subscription if it doesn't apply or if you don't think it's worthy. But you can keep on the subscription if you feel like the information is worthwhile having. I'd like to include references as well as workbooks, and just to kind of turn you into a physiologist. It's not that your doctors don't understand physiology. I think your doctors, number one, don't have time to talk to you anymore. The nature of modern medicine prevents that. Number two, they may not fully get the point A to point B. Depends on what they do for a living. And the third issue is, no offense, doctors can be jerks. And some of them may not think you're smart enough to figure it out if you sat down and had a conversation with them. So my job is to be sort of like the Sherpa guide, like the intestinal health Sherpa guide, the microbiome maven, so to speak, that is going to take the literature, show you what the resources, what the research shows, digest that into a one-page PDF, sometimes 2 pages, with some actionable things that you can do on that topic, and then dole it out on a once-a-week basis with some specialized content that only you would get as a paid subscriber. I will continue to have some free information online, obviously, because I do have an educational mission. But in this way, I can try to educate the masses on exactly what it is that's happening, and in a way that you can make an informed decision for you and your family on how you're going to live your day-to-day basis. Because if you do not have the information, you cannot possibly consent to what they are doing to you. Whether it's a prescription medicine or a food or your LED lights, believe it or not, are negatively impacting your health. The 5G, the sounds that come from your electronics, even though your ears cannot perceive it, the cells of your body absolutely can perceive it. So but if you don't know that, sure, you'll consent to an LED light bulb. It saves you electricity. Let's switch them out. Now, if I told you that that LED light at its whitest and brightest, like the one I'm under right now, is telling your brain it's high noon, Am I surprised if I'm reading a book at night to that bright light and then turn it off and I'm trying to go to sleep and I can't? Maybe I wouldn't consent to this white light in my bedroom at night if I knew that information. You can change the wavelength of that LED light to something a little bit more amber, and that amber light does not cause that sleeplessness effect that the bright white, this blue wavelength does. So simple things like that, if you knew, I think you could make better decisions for you and your family and change the way you live, and you'd be surprised how much better you feel. All right, well, I've blathered on again. Look at that. I have a gift for gab. All right, well, I hope you guys enjoyed Journal Club, and I look forward to launching this new Gut Check monthly subscription, probably in time for Christmas. So I am hoping this is something that you'll give yourself and your friends for Christmas at $6 a month. It doesn't seem like a big outlay. And in this economy, maybe $6 a month is too expensive. I don't know. I have to do some research. I think that's what it's going to wind up being. All right. I hope you guys are doing well, and we'll see you.